Good day, everybody. Welcome to another edition of the Value Analysis Expert Series. My name is Skender Daerti, and I am privileged today to be joined by the three foremost experts in value analysis, thought, and strategy, Barbara Strain, Jenell Robinson, and Terri Nelson. Welcome, ladies.
Thank you. Thanks for having us.
Good afternoon.
So, in pre-production, we were talking about a number of things, and I think so many people, when they approach value analysis, they use the hope as a strategy, right? Let me just see if I can either throw a bunch of stuff at these people and see what sticks, or let me throw nothing at them and just wing it. And hope is not a strategy. So today's episode, we're going to be talking about what are some good strategies to potentially approach, to broach, to ask about, to get feedback on, to potentially come to the discussion with, and see if you can get some insights from people such as our esteemed panelists here, who can share some information. Now, we aren't talking about contracting necessarily with supply chain people, right? This is contracting from a value analysis perspective, who's going to eventually work with the contracting team to put the final terms in place. But what we're talking about here is, how do you come to the value analysis with a strategy in place, talking in lines of their terms? So many companies come to the value analysis process and say, this is the way I approach it. Well, if you don't speak the same language as the people across the table from you, then you need a translator. And that's what basically our group is hoping to do today, is to provide some translation. So I'm just going to ask real quick, what is the worst approach you've seen? Yeah, go ahead.
What are the worst? Can I just add a little bit more, because I know you love it when I add a bunch more type of
love it, Terri.
Information. Because when it comes to contracting strategies, value analysis wants to be part of that. And it depends on the organization. So I worked in an organization where we were joined at the hip. And so is Barbara and Jenell. So we knew the contracting groups that are going to be there. But that doesn't exist in every organization. So you're going to have other organizations that are the value analysis is the implementer. So contracting strategies have been developed not considering what they need to do to implement, right? So that's part of what we want to understand. It's both implementation and best practice. And I know the three of us have gotten together and we talked a little bit about how important best practice is. Great contract, but doesn't meet the requirements of care, the standards of care, or best practice of care. Then it's like you just did a great contract. And that's contracting did, right? They did a great contract, but we will never be able to maximize its effectiveness. So we wanted to share with the audience a little bit about how we're not the writers of the contract, but we have to implement them and maximize their value to that. So I will turn it to my esteemed colleagues there now.
Good point, Carrie.
No, I think
Terri,
it's a great point,
off,
Terri. Thank you.
Yeah, I'm going to take off from there just a little bit. So, we sit and go through all of the clinical pieces, and we want to look at the general thing is value equals outcome divided by cost, right? So all of that contracting stuff gets in there when it's all the cost thing, but we want to know, what is your product or service as far as the highest value you can bring us, and how relevant is it to us? And then from there, we start to sort of think about, what are all the things that need to be in a contract that could be helpful? So there's all kinds of different ways to approach it. So what we're trying to get through to you all is that we want to educate you on the language you could use that's really going to be meaningful at that stage. So what you need to know is, we will be talking with contracting and reviewing those things to make sure that all of those goods and services we really need are covered. And regardless if it starts as a GPO contract or whatever, there's local things that we want to be able to assure that's going to be beneficial to our organization and our patient and our outcomes.
So what are some of those core tenets of language that we're talking about?
Well, I'll just start there a little bit. And I don't, it's volume over dollar, right? You spend, so the contracts can be enhanced and drive additional value if you started out by spending 100,000 in a category, doesn't matter what it is. And if you increase over the life at certain intervals, you're going to get additional value. That's great in theory. But if we've become more efficient as an organization and that 100,000, now you gave us a price break. And we've also had a change in practice where that's no longer the primary product use for whatever intervention. And we've all experienced interventions that I think of thermometry. It used to be you took the patient's temperature and the probe covers. I know this sounds very simple, but the probe covers were calculated at a certain volume. Well, then when the practice changed and you didn't take them as frequently for a variety of reasons, that number, that metric that we had to hit was never changed, right? So that's where when you simply look at dollars that you want to increase the spend when the volume is going down, that doesn't help you to do that part of it. You really need to understand how that product's used or the product category is used within an organization.
And are you asking and Jenell, building off of that, are you asking the provider community to come in and talk about new standards of practice? Is it one of those things where the expectation is that you have an idea and they should be mirroring? Help me understand who's kind of level setting what Terri was talking about.
I think that's a great question, and I think the answer is possibly a little bit of both. Value analysis professionals are quite savvy in keeping up with the current standards of care and changes of care. And because we're in the throe of things, in the throe of new emerging technologies or the new and improved, whatever it is. So I think from a supplier's perspective, honesty is key. If you developed, you meaning, the proverbial you, developed, the latest and greatest implant 20 years ago, and you had at that time or whenever the last contract was negotiated, 80% commitment, that's fine. But now 3D patient preference or, patient directed therapy has come out, and all these patient specific 3D imagery implants have come out. So is yours still the latest and greatest? And should we still be held accountable to that 80% commitment, that monopoly on that? So I think, it's just sitting down and having an open and honest conversation and being amendable to the change in times. And not rigid just because it's a 5-year contract or whatever the term may be, that no, you need to maintain 80%. But if that standard of care or if evidence comes out, or God forbid, a recall comes out, the institution should not be penalized for that. There should be an open communication to renegotiate.
The 80%, correct me if I'm wrong here, the 80% number is based on total volume, but if total volume declines, right, if it was at 100, just using a number, and then it goes down to 80 because standards of practice, as Terri drew out, then it's 80% of the 80 now, right? Not 80% of the 100 before, right?
Correct. That's the flexibility part that you have to negotiate because our sales tracings, the information that we get about volume usage is actual. It's actual time. We can go in and run a report and look at that. Where some suppliers now can get data sooner, but a lot of times there's a delay. And that's where you might start some friction with that.
And an interesting concept that we had generally talked about before we came on air is, are there dollar commitments or are they widget or volume commitments? So you have to be really clear about that as well.
Well, and I think one of the things that plays into that, Barbara, is what's a saturation in the field or within this product category? I use the implant. I always use the implant, example where there's a hip implant and you have the latest and greatest hip implant, but there are also 7 other manufacturers that manufacture hip implants. So who is your customer? Who are you talking to? Are you talking to an academic medical center that typically has more than one, more than two, sometimes multiple vendors, and they will never be able to meet your commitments?
Mm-hmm.
Or are you talking about the privatized facility that may be more standardized than the academic medical centers? And then there's everything in between. So I think moral of the story on that, before you even get into the volume and commitment conversation, is really understand and be flexible to also try to come to the table with a win-win situation for your customer and for your company. Because not every hospital is the same.
Yeah. So, Skender, you kind of asked a little bit about, what sort of a worst case or what sort of a scenario do you really hear? And sometimes it's, well, this is all we're allowed to do, or this is all our company can do, and that's their mantra, no matter who they're talking to Jenell's point. So knowing your, provider and what their mix and what their surgeons are doing, or their cardiologists are doing, or whatever, is paramount to any conversation. So you just can't come in and say, hey, this is the way we operate and this is what we're going to do. And if you go with us, this is the commitments you will have to make and those sorts of things.
So you're saying a supplier coming in and asking for a dollar commitment versus a unit volume commitment.
Mm-hmm.
There needs to be flexibility. And when, I guess from that perspective, is there appropriateness for either? Is there more appropriateness for either in a certain circumstance or another? Terri, you're nodding.
Yeah, I do think there is. You think of highly commoditized product categories, right? Low dollars. So you just don't want to, the volume isn't going to change. I want the best pricing I can commit to. And you give me, and I will commit this volume to you, right? So it'll continue to grow. If you want to use dollar there, and as long as we understand that there's not going to be a switch in the volume, I don't have a problem with that. That's a highly commoditized. Now, it's a little bit different with other product categories, and it's based on the nature of the category, which I think all three of us have kind of alluded to. Where's your practice going to go? One of the things Jenell said, and I think all of us can experience, if you have facilities in multiple locations, there's sometimes an expectation from the supplier side that you should have spend in all those locations. And if we're doing our job right, we shouldn't. We should be looking at a formulary and making sure we got the right patient at the right location and they're getting those products correctly. But if you're having an open heart procedure, you better be at the bigger facility than there. And that's where you expect to see those product categories used, right? So it's understanding, and that's what Barbara just said, understanding the organization's practice and structure is important for them to build a good contract.
And Terri kind of alluded to, if you do it dollars, but part of that whole negotiation is a better price and the volumes don't change.
Mm-hmm. So
or other factors come in there, you'll never match the dollars. That happens in what we're calling overlays, right? Yeah. If a company that has lots of different divisions says, if you buy so much from each of our divisions and they all add up to a certain amount, then we'll give you rebates back or some sort of fees back or whatever. But if you're getting better pricing as part of that, you'll never reach that bar. And that's what happens most. So the offer is too good to be true. So you have to be careful about those. Getting back a little bit more to the value analysis side and talking about, outcomes, I think one of the things, and this will spur more conversation here as well, but say we have a fairly high rate of healthcare pressure ulcers, that we have. And so somebody comes in and says, well, we can take you from this level to this level, which other companies can't do, and it'll help, I always do wound care and stuff in a big pie because there's so many different ways in which you can cure sort of various things or prevent it. And the thing that you have to do is, well, what are you willing to share in that risk with me if I don't get those levels down to that level? So that's one of the things is risk share. Uh, Jenell has opinion about
Yeah.
risk share.
What's your
Um,
opinion on risk share? Share that.
Well, I think it can be a challenge for some organizations to do risk share for a number of reasons. You're talking about following outcomes depends on how far out. Who is going to do that? Unless you elicit help from other departments to get it on their radar to actually track those outcomes, it becomes a challenge, and so just, I think, but a way to combat that is, if risk sharing is absolutely part of the model, is taking a realistic approach to it, and not making the outcomes so challenging and so complicated that they're difficult to track. Number one. Number two, I think, is, again, understanding your customer. And it may be a great buzzword, risk sharing, and it may be, wonderful from a marketing perspective, but understanding who your customer is and what their patient base is. There are factors, take skincare, for example. There are certain factors that predisposes patients to a higher skin risk that may not be seen in other parts of the country for one reason or another. And that has to be taken into consideration and realistically looked at to see, can the organization even attain these goals, given their patient population and demographics and all of the other factors that go into, the overall care of the patient.
Because the product that you're working with the supplier may not even factor into whatever's causing those skin conditions.
Right. Correct.
So it's not going to make a difference. So it's a little slippery slope, but people will throw out those kinds of terms and things because they might have had success, which usually happens more in purchase services, like with equipment maintenance or things like that. There's easier things to sort of look at.
I think that's changed a little bit. I agree with everything you guys have said. And 10 years ago, I would fight it because it's like it required a whole different area to collect the data that you were asking. Data wasn't easily retrievable to get to. It wasn't accurate. Things that Jenell said, it's all based on the coders and what the coders say, because it's your reimbursement and all of these factors. But that's been tightened up over the last 10 years. And now with databases that we have, we know that as providers, we can look at the patient populations that we're providing care for and what their common DRGs are, or procedural codes that they have, and what that looks like. So we need to understand that that's where I think risk share has a place now. It's maturing and becoming more of partnership with the providers and the suppliers, not a penalty, or a wave. Both of you said it's not saying, hey, see, I'll do something nice to you, waving this flag. That we all sat there and said, there's no way in H I'm ever, hope I can say that H, the letter H, achieve that outcome. I can't do that. But now we have hard data. And the suppliers too, now you're talking to the data people, how much are they going to want to look at ahead of time so they can actually come with kind of a risk share that will generate value for organizations. And that's even available now. So I think when you're doing contracting strategies and looking at risk share, it's understanding you're not putting a burden on the provider, but you're doing that relationship. Which, this being our third podcast, we've talked about relationship building in every one of them. That's key to success.
Yep. Got to learn.
So go ahead, Barbara.
Go ahead.
No, go ahead, Barbara.
So I was just going to talk about a little bit different type, not quite risk share, but there's still elements of trying to get the value-based care and away from fee-for-service. We're not even close to doing that because there's so many complications. And now with all the different potential practice changes, but regulatory changes and pricing and tariffs and a variety of things, people may not be willing to take some sort of a chance or go off sort of in a different pathway and things. But value-based care is been my mantra for quite a long time, because if you pay enough attention to what's going on in a community setting, so if you have a product that even is only really used in those high acuity situations in a hospital, but you can suggest things that could happen outside, you could have the best of both worlds and kind of look at that value-based care thing. But anyway, that's another thing to think about, because value analysis is going to think about that, because we have the home health people at interest, we have physician offices or clinics at interest, and doing a whole care across all the patients that we would possibly have. And again, if we're a large center, that means a lot more than maybe a small place, but we could be aligned with someone else. So knowing all those things are important.
So let me ask a question, and this is going to sound relatively simple, but I think it has big implications. How often, in a scale of 100%, what percentage would you say that value analysis gets to be more proactive to circumstances, to changes in practice, to changes in macroeconomic, macro societal aspects versus reactive to what's going on around them? Do you think value analysis gets to be on the hot side of more proactivity, or is it more reactive?
Well, I'll just jump in there. I think it depends on the organization you're with, right?
Okay.
So, my experience with value analysis is we were always joined together. That's one of the reasons why when the program was set up, we didn't have value analysis reporting to contracting or procurement or somebody else. The idea was they have to be at the same level with the groups that they're going to provide support with. So that was always the structure. So I think that helps you. And then just what all three of us have said is we do, and Jenell did a great job of identifying, we look at practice. I'm not an expert, but I do read it. I know Barbara reads a lot because she sends me notes saying, hey, did you see this? Like, I haven't said that yet. And as well as you do, as Skender, and I appreciate that. But that's why we keep current, and we're not doing our job if we're not pointing out to our contracting colleagues, hey, when you do this contract, so you need to consider X, Y, and Z. That's why we worked out the calendar, and we worked 6 to 9 months to a year in advance, depending on the product category, to say, we know this is coming down the pipe. So you need to be aware of that when you're doing your contracting strategy. And that might be different for Jenell's group. I'm not sure about that, but that's one thing that we looked at in advance.
Jenell, would you agree? What do you think?
I would agree. I think we have to be proactive. You have to understand and know what's coming down the line, what is changing, how are standards changing, the current evidence that supports the change in practice. And any established, I think I agree with Terri, and then I think it kind of depends on, the seasonality of the program, the value analysis program and the people that you're talking to. But those programs that have been a while, that's really become part of their everyday minutia. This is what we do. This is what we look at. This is, when faced with a contract or an expiring contract, the first thing that should come to mind is what has changed? What has changed since last time, and being proactive with that, and, protecting the patients, protecting the organization, protecting the physicians, and working that or any changes into that then upcoming contract. A great standard of care example is traditional surgical approach versus minimally invasive. Look at how spine has changed over the years, where now there's more and more minimally invasive. So when it comes time to negotiate those contracts, let's take a good look at it and see if it can still be achievable with the changes in practice that have occurred in the last few years.
Because a lot of suppliers start with their design or update of new products about 3 to 5 years before they're ready to come to market. Well, in that period of time, and they're excited about selling now. And we go, well, we've jumped that curve already and we're starting to do this. So that really isn't relevant anymore. And how do they change midstream? How do they keep up to date? I can think of just one, professional societies help to guide changes in practice. So when the practice of changing from IVs lasting, 48 hours and changing to 72 and then talking about even changing later hours, that doesn't wait for a contract to end. The practices are constantly being reviewed and looked at because you got to take the waste out of the practice and you got to update things. But in organizations, you also have to have the right mix of physicians, clinicians, and techs that have the ability to make those changes in practice, regardless of the product, because they might not have the know-how or the where-how to do those sorts of things. So you got to strike these balances in there, but keep up to date. So I can see this playbook sort of developing. It's not just, we're out there to sell the product, but we have to include all these other questions ahead of time that value analysis is keeping up with because either their nursing colleagues or their radiology colleagues or whoever it is saying, hey, we really want to look at. So when we get new product requests, a lot of times those yield, let's look at the whole practice request when you look at that, because now you're going to head down a different path and it may affect everything from how a patient is admitted, how they have procedures done, down the whole track. And so it can upset the whole apple cart. So great question, Skender, but proactive.
I think just to add on to that, Barbara, is just for suppliers to fully understand where their customer that they're talking to is in that change of standard practice. It's not like you flick a switch and the whole country changes at one time. So really fully understanding where they are within that evolution and that change in standard of care and what their current is, it can help a lot.
Yeah. So it influences your current contract and then anything else you might have to go forward.
Yeah.
Now, despite that there are standards, and we're going to be wrapping up here soon, but I'm just curious because I know I've experienced it. Have you ever found yourself at odds with a supplier when it comes to the dynamic? And I'm not talking about contract. I'm not talking about pricing. I'm not talking about those things. I'm talking about standards of practice, right? Have you ever found yourself at odds with suppliers regarding standards of practice? And what is the best practice? If you're a supplier then is coming to you and saying, hey, AORN just said this, or AAOS suggested this, and you're not seeing it, you didn't hear it, maybe you have awareness to it, but it's not happening. Maybe it's too proactive. Maybe it's an initiative they talked about for 2028. Like you said, they can't flick a switch. What is a good practice then for both sides to engage in at that moment?
Yeah, I did. I just remember this argument went on and on for several years about because it was some kind of custom kit that we had and the supplier refused to put in the product that we wanted because it was best practice. And they said, just what you said to me was like, well, no one else in the country is doing it. They're all using X. And I said, guess what? This is better practice. And if you get ahead of it, you won't have as much to discard in a few years. Or do you want us not to use, because we could go to a custom and with a different supplier, right? Because you can't meet the needs that you have. I hate to use that leverage, but that's the reality that you come with. And it depends on the size, just what we talked about. That friction does happen. And when you're dealing with large academic medical centers that do research and what have you, and are setting on boards that are generating best practice. We've all had the physician who's called us and said, it's not happening now, but in 2 years, we're going to have X, just what Barbara had said too. And I want to get ahead of that. How do we do that type of thing? So working together, not creating friction for them, helps us all with that, including product disruptions. Because if you are the provider or supplier and you're trying to hold that change too close because you don't want to have waste, guess what? Somebody's going to have a back order somewhere, and it's going to be a major upset, especially if something new is coming into the environment. So we're colleagues, right? And I just have to add it on there. It goes on to relationships. I like basically everybody. No, I really do like everybody. It's not about being my best friend. It's about that patient at the center. So, right, we said it from the first podcast. At the center is the patient. And as long as you keep that, you will make the right decision. You might not like what I said, but you make the right decision for the patient. So,
and Jenell, what do you think about being at odds? Like, what are some best practices for both sides there from your perspective?
Well, I think, you have an obligation to your patients and to your organization. First and foremost, like Terri just said, it's the patients. And so if a supplier can't understand that the pillar of your decision making centers around the patients, that may not be the supplier for you. And that's okay. Yeah. Because ultimately we answer to our patients.
Very patient centric. How about Barbara? What do you?
So one of the things that normally happens, at least we had conversations like that. A supplier might mention, the latest thing, and we just sold this to, and they'd mention either a Mayo Clinic or a Cleveland Clinic or somebody. And we'd say, well, why don't you show us the evidence? Let's talk about how you got to this product. What were the practices you reviewed? What were the references and things? And let's have a conversation about that. And rather than make it adversarial, let's make it educational for both sides. Because it could be that our patients just don't present like that, where some others might. So that seems to be a common theme today that we've talked about. The other thing is that their product may be missing one little thing that doesn't match up to 2 or 3 other practices that go along with that particular one that they're looking at. So sometimes you just are at odds with the mix of equipment or the staff that you have. And so it's best for our patients to stay where we are, because then we would have to change too many moving parts that then might upset a whole protocol or something like that. So it needs to be more educational at those points.
I think one thing that I would like to think we've all thought about it, but no one said it, is there is power in physician preference. There are some items that it doesn't matter, how wonderful it is that Cleveland Clinic has it, that Mayo has it, that you sold here, there, and there. There are some physicians who they like this, they like what they want what they want, they like what they have, and it's going to be very, very challenging to try to get any movement or any change within that.
Yeah,
and that's
one of the first lessons one of the first lessons I learned is I don't care if Duke or Cleveland Clinic or whoever, it's really what Jenell just said. It's really just, what is our practice or my practice going to be?
Yeah. I think if it's approached as a partnership versus penalty mentality, that's a win-win for both sides. And that's the best case scenario that you could ever have to open those doors to conversation.
And I think that has more opportunity to be the case in value analysis, where you're looking equally at outcomes and cost, as opposed to resting the strategy when it comes to just straight contracting people who are very much caught up in the dollars and cents, right? So here's an opportunity to build an advocate, build that strategy, build that relationship, and then maybe value analysis can be the advocate when you start talking tiers and whatnot. So I love it. Ladies, this has been a very profound discussion. I really appreciate it. Let's, if we can just get some final thoughts from each of you to leave our audience with in very brief fashion as we wrap up here. Terri, you started us off. Why don't you kick it off on the final thoughts?
Actually, I was thinking exactly what you had just recently said is value analysis. That's the nature of what we do. We don't live in a closet. We're not closed off. We live in everything and look at everything that's going on and develop these relationships, which again, I said 6 times in this podcast, if anybody's counting. But I think that's when you're looking at contracting strategies. I don't expect the supplier to understand everything, but I just expect them to ask the question. I mean, it's our job to understand our organization, how we do it.
Yeah. Barbara?
Well, I think it will all figured out, and this is kind of lessons, whether you're a supplier listening to us or a provider listening to us, is value analysis and contracting need to be sort of together on all of these and not do them either one in a vacuum, overpromise, underdeliver, because that patient is out there. And so we all need to be working together and not sort of don't split it like a mom and a dad and the kids going to one and dad said yes and mom, what about this and that? So it really goes well for the whole relationship building.
Good. And Jenell?
I don't have a lot to add. I think Terri and Barbara haven't already said. But, Terri uses the word relationship, I think. Is that what you said you use, Terri? Yeah. I use partnership. Same thing. I've said it half a dozen times, and because it really is a true partnership. And I think from a supplier perspective, if you can approach your value analysis professional with that in mind, that, hey, we're going to develop this partnership or grow this partnership no matter where you are, because when you do that, it's a win-win. It's a 3-win, right? The patient wins, the organization wins, and the supplier wins. And, I think just have some flexibility for variation amongst your customers is, and nobody wants to say, oh, I'm unique, or maybe everybody wants to say, well, I'm unique, I'm not like that. But in reality, there are some unique qualities for each organization that you're dealt with. And I think that partnership versus penalty is pretty powerful.
Yeah. Ladies, thank you so much for imparting your wisdom. I think this is incredibly valuable for everybody. I will speak on behalf of the supplier community sometimes, right? There's voodoo thoughts sometimes when it comes to value analysis, but I think the idea of
we're touchable.
Value analysis, it can be a partner. Value analysis should be a partner. Value analysis should be approached in a way of advocacy. And I think if more of the supplier community starts to understand that and embracing that, it's going to lead to much more effective conversations. So thank you to each of you for sharing that and imparting that on everybody. To the audience, thank you for your time. We really appreciate it. Please stay tuned for following and subsequent conversations, as there is way more information and wisdom to be coming your way. Thank you.